Today, we'll reflect about what initiatives that the European chapter of Academy for Eating Disorders developed along this period. It's about the assessment of people that we receive, the new people, the new clients. With them, we want to offer an opportunity to enlighten better which is their orientation, sexual orientation. And so we suggest to the units, to the colleagues around the world, if they want, to introduce in the tools inside the assessment these little questions that can help everybody to open also this aspect of the human sexual orientation. Along this webinar, we present the work that European chapter are developed along this period with a group of colleagues led by Lia Manzato, and so she'll present this little history about this recommendation. After that, we want to offer the presentation of the tools and a little brief vignette, clinical vignette, when somebody can understand what we are trying to suggest to introduce in our daily practice. And so this is a webinar very practice, very concrete, to realize together a little change inside our style of assessment. And we want to start since today a study together introducing this kind of approach. Thanks to everybody, thanks to the group that work inside the European chapter to develop these tools, this assessment, and thanks Lia that now introduce our recommendation.
Thank you, Umberto, for your kind presentation. Now I'll share my slides. And thank you for the presentation. And we have written the recommendations starting from two main considerations. The first one is that epidemiological data show that there is a high percentage of eating disorders in sexual and gender minority people. But in our clinical practice, we treat a very low percentage of these patients. And the second point is that the low presence of these minority sexual and gender patients could be due to the difficulty of these patients to ask for a treatment, particularly for the eating disorders patients. But it could be due also to the incapacity of the therapists to recognize the sexual and gender minority patients. Overall, if they are in the questioning phase or if they hide their gender identity or their sexual orientation. So we decided to write this document to improve our capacity to support these patients. First of all, the LGBTQI+, what does this acronym stand for? It defines a sum of different sexual and gender minorities as lesbian, bisexual, transgender, questioning, intersexual people. It includes also all the sexual and the gender minorities that have not been studied yet. For my convenience, from now on, I will use the definition sexual and gender minority people, patients, instead of the acronym. So these people are high risk of mental diseases, including eating disorders. And scientific data show that individuals in the sexual and gender minority people are more likely to experience a body dissatisfaction that is a core stressor for eating disorders, but also weight concerns and disordered eating behaviors, more than cisgender and heterosexual people. Furthermore, the research data point out that the most important thing to favor the recovery for sexual and gender minority patients with eating disorders is to support their visibility. It is therefore important from a clinical point of view to improve the clinical approach to minority people with an eating disorders, considering sexual orientation and gender identity as essential variables during the treatment. I'll talk about the topical mentioned in the introduction: biological determinants, environmental characteristics, body dissatisfaction, epidemiological data, and the manual of the classification. Biological determinants. The epigenetic model states that the minority sexual and gender status depends on the epigenetic factors, in particular during the development of the brain in the third trimester of pregnancy. Some of these epigenetic changes are very important in the field of eating and nutritional disorders. Furthermore, it has been supposed that mothers with polycystic ovaries and tendency to hypothyroidism have more possibility of giving birth to minority sexual and gender children. In particular, in children recognized as male at birth, gay male, bisexual males, transgender women, the tendency to hyperthyroidism is linked to the high presence of low body mass index. In children recognized as female at birth, lesbian, bisexual women, or transgender males, these epigenetic factors are inherited, and they contribute to the more frequent presence of obesity than in general population. So, the fact of being a minority sexual and gender people nowadays is considered to be a consequence of epigenetic factors that could be also linked with a high percentage of obesity in the minority and gender, minority sexual and gender persons recognized as female at birth, and thinness in the minority sexual and gender people recognized as male at birth. These epigenetic factors, along with environmental factors, could have an important role for the eating disorders enonset. Environmental characteristics. We know that the most important factor, environmental factor, is the discrimination. the minority sexual and gender people are often discriminated in their family, in the school, in social relationship, in the scholar context, in the work context. They live social discrimination and prejudice, social stigma, victimization, reduced support, family and social support. In particular, minority sexual and gender children or adolescents in the so-called questioning phase could experience a different level of distress. In this phase, in fact, just to understand who they really are and coming out or to be visible could be very, very difficult. Body dissatisfaction, several theories, particularly minority stress theory by Meyer, state that social stressors related to their minority status could be one of the most important causes of high percentage of mental disorders, but also be one of the most important causes of high percentage of eating disorders, pressing the sexual minority and gender minority population to have the ideal body, promoting greater thin or muscular ideal body internalization, and increasing risk of illicit use of appearance and performance enhancing drug and supplements. And the epidemiological data confirm that eating disorders lifetime prevalence is very high in minority sexual and gender population. In the main eating disorders as anorexia nervosa, bulimia nervosa, binge eating disorder. But in particular, gay and bisexual men have a very high prevalence of symptoms of eating disorders, as fasting, dieting, skipping meals, purging. The use of diagnostic and statistical manual is not recommended because it treats only psychiatric disorders, and the item gender dysphoria is inserted as a psychiatric disorder. Instead, the International Classification of Disease is a manual for all pathologies. In the last edition of the International Classification of Diseases, there is a new chapter dedicated to conditions related to sexual health, where gender incongruity of childhood, adolescents, and adults has been inserted. Our recommendations for clinical approach of eating disorders in minority and sexual patients are focused only on the clinical approach, not on the type of treatment, because the absence of knowledge and of positive modeling with consequent risk of discrimination often involve healthcare staff. We know that research data show that support their visibility is the most important therapeutic action. In detail, the European chapter recommendations consist of two main points. The first one is the sex and gender orienting questionnaire. The second one is affirmative reception for minority sexual and gender patients. Our aims. The first step is to share the document and collect the comments, suggestions from our colleagues. The second step is to promote the use of this tool with our eating disorder patients. I underline that the questionnaire must be used with every patient, not only with the sexual and gender minority patients, to improve the capacity of the therapists to recognize the patients of these minority sexual and gender populations. Lastly, we'd like to organize a small pilot research project. For example, if each of us used the questionnaire with at least 10 patients, we could enter the data into a database and evaluate the results, discuss the results, and share their experience. Manlio and I presented the recommendation in the last National Congress of Italian Society for Eating Disorders in Naples at the beginning of November, and 6 Italian eating disorders centers have accepted to be involved in our research. Thank you for your attention. The chair at you, Manlio.
Thanks a lot, Emilia. Thanks a lot, Emilia. It's important what you said when our suggestion is to introduce this tool for every client, every new client. And the other is that we are open to accept the other contribution for colleagues from everywhere to participate in our initiatives. I don't cite at the beginning the name of the group members that developed this kind of project inside the European chapter. They are Lia Manzato, who led this group, Mario Converti, Paolo Meneguzzo, Paolo Crapanzano, Josie Geller, and Elissa Meyer. Thanks a lot. This is the group of presenters of these initiatives. Okay, Mario Converti, psychiatrist, president of the AMIGAY, the Italian Society of Doctors LGBTQI, present the tool.
Oh, thank you for this presentation, especially for Emilia Manzato, very nice and a very simple speech. I hope everybody here coming from different countries would agree not only to accept themselves, to begin to use our tool, and I will explain it also, just leave me the time to show you, and also to share it in their own countries, on to produce other webinars to give this kind of instrument to other persons, especially in Europe, but eventually also in the world. Because as you have seen, Emilia gave you a little kick of epidemiology that's signed by Mr. Nagata. We had it last year, a webinar with him and his group. But Nagata is an American person, is a United States professional, and his epidemiological data only depends because since 2010 in the US, federal so governmental offices use some inclusive data. The problem is that those data are prepared into an English word, into an English platform, using usually specific terms that we cannot translate in any language. We cannot translate straight, as an example. Cisgender is quite impossible to be understood outside USA. I don't know if quite all of you are cisgender maybe here today, but maybe you don't know what does cisgender means. And this is a problem also, the pronouns questions. I've seen before Miss Dawn Gazons was using aside her name and surname, the pronouns she, her, indicating her identity gender. This is very important into an English word, but outside of it is absolutely useless. In Latin languages like Spanish, Italian, French, Portuguese, I'm not sure in Chinese or German, sorry. I cannot know all the languages, but I know mine. And we don't use pronouns indicating the gender of the persons. We use the adjectives. Emilia è una donna simpatica, bella. Umberto è una persona, Umberto è bello e simpatico. But it is always il mio tavolo e la mia sedia. It's never possible to say la mia tavolo e il mio sedia. This is impossible in Italian. And so we decided with my association, and I must thank Nizzoli and Manzato and Myers and goes on, to approve this project, to try to prepare this instrument. Where is the difference? The questions and the answers are very fluent in quite all the languages, are the simplest we can think to explain. If you have an electronic instrument, you have to put exactly those questions and those answers to distinguish the general population from the minority population, sex and gender minority population. If you are working, like we are looking just in a few minutes with the help of the Professoressa Ada Seguino, a friend of mine, which is helping later for this little example of a psychologist or psychiatrist or a medical relation with a patient, okay? And you can use all your languages, all your way, all your personal way to stay into the relation with the patient to obtain the same answers or something that lets you understand 5 specific points. The first 4 are the 4 axes of sexuality. That the 5th one is the most important. I usually begin from the 5th one. As also Emilia Manzato explained to you very well, the point is the visibility of an LGBTI person and also the support they can have from family, school, university, co-workers, social, society, laws. In some countries, you perfectly know I could be dead by law or imprisoned just because I'm gay. And this is a problem to come out as gay in Iran or in Russia. But if we don't do, we wouldn't have had this freedom in our countries here, in Italy, or in US, or in French, or in Spain. It's just because we came out at our own risk, trying to arise the support from society, from family, from schools and university, that we actually are free here more than in other countries. So somehow there is a link between policies and health of LGBTI persons, a very straight link that you must understand it applies differently country by country, depending the place where you live, the laws you use, and also the kind of person you have in face, if they are coming from another ethnicity, if they are migrants, if they are coming from Eastern Europe, if they are coming from South or Northern Africa or India, they are going to have a completely personal and familial prejudices about the fact to be an LGBTI person. And this is an intersectionality that is inside this 5th point. The intersectionality question is inside the 5th point. Who knows about your sexual identity? I always explain also, this today still apply in European countries about women. general women population, especially during adolescence, have sometimes problem to show their sexual identity. They are often supposed to be virgin until 40 years old, and their sexual activity is not so often accepted or beloved by their own family like it would if they were males. Males, straight males, are always supposed to be having sex with women, also at 13 years old, 10 years old, 60 years old, 80, 79, 90 years old. And the opposite, women are not exactly supposed to have these sexual activities. And this is something that is inside the eating and nutritional disorders. So this question is maybe to apply really to all the population, not only to LGBTI persons. So explaining this exactly for the sexual and minority population, who knows about your sexual identity? Everybody. It doesn't mean you don't have problems, but you have the less minority stress problems. Nobody. Nobody means you have the maximum level of minority stress, the maximum risk of anxiety, depression, eating and nutritional disorders, abuse of substances like alcohol, drugs, nicotine, and suicidal risks. Those are the 5 big risks that are involved if you have a big minority stress. And by minority stress means nobody knows about you. What about if just some friends, also parents and family, also workplace and study place? This is a very complicated puzzle in your life. So you are not completely out, you're just out in the places where you feel supported. That is an intermediate condition, but this is always a condition of crisis, because you must, and also the others have to remember that you are not out everywhere. And so also the friends of yours, have to be very careful to not out you where you have not supposed to receive a support about you. So this question is very important also for the privacy, but it's also important for the place where we as professionals can work to help that person not only to come out and to ask for his own or her own or their own freedom, but also to help the opposite side, especially the family, to come in. Because family is not an enemy. It should be also in trouble for a while, as in the grief problems. And you must support the families to pass over this kind of grief problems of the come out, coming in a good relation and supporting their son, daughters, brothers, sisters, fathers, mothers, cousins, sons. And this is also why this instrument is very good to use with everybody, because eventually the person you are using with is absolutely straight. Straight is something that in Italian you cannot to say at all, because straight in Italian doesn't exist. It's normal. It's normal. It's a vulgar word also in Italian. If anybody of your patients is truly straight, majority is going to be truly straight, they should have LGBTI friends or relatives. And if they are LGBTI relatives, they could find in you a big help, because you could help them to come in a good relation, a supportive relation with their son, daughters, brothers and sisters, fathers and mothers, aunts, etc. And this is something that is very useful. We did, you remember, Emilia and Umberto, I make this joke with hundreds of persons we have in Naples during the CSDCA Congress this November. I asked, who was a sexual minority there, and 6 persons raised their hand. And I asked, how many of you have LGBTI relatives? And more than 20 people raised their hands in at about 120 persons. This is a big number. So I don't know how much time still I have, but it was a very important point.
Okay, Manlio. Okay, Manlio, thanks a lot. Very, very clear. It's important, this kind of presentation. Today, we want to listen to also the colleagues that follow this webinar. And so after the presentation of a case...
Can I give you this instrument by the chat if you want, because you can
but we have to use the time that we have together to offer the opportunity to discuss with the people that are here. Okay?
Okay, that's your turn.
Okay. And now, after this presentation of the tool that we want to recommend to use, we want to present a brief vignette, clinical vignette, when there are a presentation of a case that arrives normally. And so you have to look at their real practice of this kind of tool with Manlio and Ada Seguino, Professor Ada Seguino, that they present like in theatrical way, as in the course of the specialization, of our specialization, a case. Please.
We are also giving you this paper later. I'll thank you again. Ada, are you there?
Yes, can you hear me?
Sure,
yes, we can listen.
We can.
Hi everybody. Hi, everybody. I don't want to take other time because it's enough.
So okay, let's go. Ada, that's your turn. Please begin.
A 40-year-old male patient comes to my office and describes his symptoms related to Dysmorphic disease. He goes to the gym 7 days a week. He uses anabolizing. He follows a high-protein diet, and he has a strict control about food upon ingredients and their amount.
He has concerns about his muscularity. He is worried of not having enough muscularity, and this problem creates him a lot of discomfort in social and emotional relationships.
The patient is very embarrassed to talk about his eating problem because he thinks that eating disorders are just young girls' problems. After having asked him to describe his problem, he was sent to my clinic, and having tried to put him at ease, because I had seen him very tense, I asked him to talk about himself, his social life, his relationships, etc., to get to know him better.
He talks about his work, his family of origin, his social life, and when she asked him if he has any partner, he tells he has one, showing a certain embarrassment.
I asked him if he had any previous relationships and if he's happy in his current one. I asked him if he agrees to answer a questionnaire that I have begun to regularly use it in my clinic with all my patients.
He specified that the questionnaire concerns personal data such as sexual orientation, gender identity, etc., and she assures me that all data will be protected by privacy. I agree, and she start the questionnaire.
Mr. Rossi, you weren't recognized as male at birth, but how do you identify yourself? Do you identify your gender identity as a male or female or as a non-binary person?
I have always identified with the male gender.
So we could say that your gender identity is congruent with your biological sex, completely or just partially?
Yes, it is completely.
Mr. Rossi, your sex at birth was male, is it correct? Or you are aware to have any intersex condition?
Oh yes, male. But I always feel to be too thin as a man.
Mr. Rossi, could we say that your gender expression is also masculine? I mean, your voice, your appearance, your movements, or do you perceive that differently? What about your attitudes and behaviors? Do your social roles in life are more masculine or feminine or neutral, in your opinion?
I would say that my behavioral traits are masculine, even if as I told you, I have strong concerns about my muscle mass. It is never seems enough masculine to me.
So could we say that your characterizing traits are masculine traits?
Yeah, of course.
Mr. Rossi, you told me that you have a partner. What's her or his or their name?
Uh, its name, his name, his name is Paul. I must confess to you, I'm gay.
Ah, okay. I see. It was really hard to you to tell me his name. I want to thank you. You did it. It's very important here. You're feeling safe and free to speak about yourself and your life. So, may I ask you if Paul has been your only partner, or did you have other relationships before? Were those only with men, or also with women or transgender people?
I discovered my homosexuality during adolescence. And it was a difficult decision. My family would not have accepted it. Only when I was able to go away and live alone, I peacefully lived my relationship with some partner.
Mr. Rossi, so haven't you had any relationship with women or transgender people, but only with men, or just with the partner you currently have?
Well, yeah, I tried to go with women during adolescence, but I wasn't interested at all. At the same time, I felt ashamed to go with men for a long while.
I understand your great difficulty was due to your family values and prejudices, but perhaps they still were also your own prejudices, and maybe some are still here today. At least since you have a partner, have you managed to tell it someone, your family, your colleagues, your friends? Who do you share it completely with? Who are you still hiding it from?
I'm receiving a great help from my partner, but until now, I'd always eaten it to my therapists. Actually, only a few friends know about my homosexuality.
I understand your difficulties. Do you think that your eating disorder could be related to the difficulty and visibility of your sexual orientation?
I don't think. I don't know. And to me, they are two different problems with no connection.
I see, Mr. Rossi. Actually, my questions are going to be useful to allow you and me to find the best way to help you with your eating disorder. The first and important help to reduce your eating disorder is to understand how to be able to live in harmony with your own emotions. And it is well known that in homosexual people or those who belong to a sexual minority, the first step is exactly being able to talk openly about themselves in a supportive environment. I am here also to help you in this.
The difficulties that come from belonging to a concealed person can play a fundamental role in the onset and maintenance of an eating and nutritional disorder, and other psychological illnesses as anxiety or depression in general.
Mr. Rossi, therefore, gathering all information is not only a way to know you better, The understanding of your difficulties to relate with your idea of masculinity, or to openly be out with all your family and friends or with your co-workers, are the beginning of a therapeutic action, which will follow together. It is fundamental to address those discomforts that you experience every day. You're hiding your homosexual relationship. You had, and maybe you still have, a non-supporting family, and those discomforts could create mental distress. And this is getting you in trouble with your eating disorder. That's it.
That is all, folks. Thank you, Ada.
Okay.
She's also my professor.
Okay.
My
in English
pleasure.
sometimes.
That was my pleasure.
Also our pleasure, this presentation, because it is something that everybody feel close, because it's
And
our
we thank Lia
profession.
Manzato because she
Our
brought
profession inside the session. Okay, now we have some time. If you have questions, you can write in the chat and we try to answer. But I repeat, we want to develop these tools in different units, in different countries, and organize together a research. Please, there are someone that introduce a question that you received. Emilia, you want to answer to him? The question is,
please, Umberto.
Fabrizio Santonicolo, I'm a student with a project on
Yes.
image and disorder, eating disorder, LGBTQI plus people. Could I ask if, either in research of your clinical practice, you have encountered any specificities regarding alternative body image ideals existing in LGBTQI community? For example, beer, other, twink, batch, chapstick, or others.
I like to underline a little thing that we are in the first step of our research, and we need to translate our sex and gender orienting in the different languages. So we need also the help of our colleagues from, for example, Spain, from French, from Germany, to translate this from Italy. Mario Converti and I will translate the questionnaire, and we can use the questionnaire with our colleagues that are projecting, that have different projects. Every project focused on the body image, for example, or for eating disorder, and so on. So we can add our Italian colleague, I don't remember the name, but we can be in touch with him to continue our research. I don't know if I have answered.
I want to share with everybody that Eva Trujillo, she's a very important representative of the Academy, right? That she is interested to introduce this tool in the South America, and also to translate it in Spanish and validate it. Thanks, Eva. Thanks, Eva, very much. You are a leader. Please, other questions? Perhaps we need to offer the opportunity to use this approach more briefly inside the assessment, because we need to maintain concretely the opportunity to the services to use it every day, daily, with every client. Thank you for your informative presentation. We must leave to another meeting. Okay. Thanks a lot to everybody. Other questions, if you ask.
Umberto, I'd like to add that the clinical case with Malion and with Ada is easy, I think, clinical case. I mean that in the clinical practice, our patients maybe are more in difficulty to talk about their situation. So we can use this questionnaire when we have a good relationship with the patients, maybe not in the first access, for example.
In the first minutes, not.
Depends on the situation.
Exactly. Our advice is not in the first minutes.
No. Another point to express is the questioning, because the person before said a lot of sub names. Questioning is another name of a portion of an LGBTI population, especially in the adolescents. In the adolescence, you have a lot of young persons that doesn't arrive to say about themselves who could they be, if they are exactly gay or bisexual, if they are transgender or non-binary. Those are very special persons. They are maybe more in danger of eating disorders than other persons, because to be questioning is a stress moment. I don't either those, especially adolescents, I repeat, maybe don't really understand the difference between intersexuality, transgenderism, homosexuality, bisexuality. They maybe could understand it, but they couldn't accept the fact to be in the middle. Non-binary, bisexuals have sometimes also discrimination by the same sexual and minority population, because a lot of LGBTI persons begin to say, you are not bisexual, you are just a lesbian girl or a gay man that doesn't really accept yourself completely. Or for non-binary person, you are a transgender woman, but you are transgender man, but you don't really accept yourself completely. And this kind of distress by the LGBTI population is a big problem. Another problem should be, and this is something that in questioning person must be in help, this instrument, because if asking one by one the access, you could explain maybe those people the difference between them. I see there is a lot of other maybe questions, Nizzoli.
Oh, I want to give my greetings to Eva Trujillo. It's my friend.
Okay.
She's in Mexico. She's very important. I want to say to her, happy to meet you in this webinar. And
Miss
I want also
Trujillo,
to
very happy. Please work on this in Spanish. It's very easy to translate it.
Okay, Mario. Okay, there are many people here, and also Karim El-Kazen is interesting to translate it in Arabic. That is very also so important. We, as European chapter, we are working to introduce this opportunity, this kind of approach at the beginning of the treatment, in the period where we call assessment period. Normally, it arrives to be 40 days, not more. Along this period, we want to use these tools. After that, surely, we have to study if there are some treatment more specific for them, but as European chapter, we haven't an opportunity to present this kind of treatment. We want to discuss and to research together. Now is the recommendation to introduce this tool for all the clients in the assessment period. Also, if you have other question, you can. Everybody can put question.
Zannini, Angela Zannini, I suppose in Italian, because she wrote in Italian. A fundamental thematic to her is how to facilitate the access to the population. First of all, asking to everybody this questionnaire in the way you prefer, as Emilia always explained. This is a way to let share to the world that your working in a way that helps LGBTI people. Another way, very stupid, but at the same time very easy, you can put something like that, a rainbow, or a rainbow flag in your study, or outside, if it's especially if it is a public study, or if you can prepare a congress or a portion of a congress about this argument, to share this to all the other professionals, or to participate yourself to the pride in your country. Eventually, this is there is a lot of instruments you can use. The more simple are evidently the flags in your office.
Okay, everybody. We want to
Emilia,
thank
she wants also to answer.
Manlio. We are concluding this session.
Yes.
I want to thank everybody. I want to thank everybody because this is an important moment to reflect, to change, to introduce a tool for this kind of approach inside our practice. I want to thank Lia, Manlio, and Ada because they are the protagonists of this webinar. And you know that we want to stay in touch together. Stay in touch with us. We want to develop this kind of views. We can reflect together what arrives in our practice to improve the quality of our practice. Thanks to Elisa, thanks to Dawn and the other friends of the other side of the ocean, because for them is the Thanksgiving Day. Thanks to be here with us, and thanks to follow the initiatives of the Eating Disorder European chapter. Next meeting should be December 14. Also, in this case, we'll discuss in this way, practically, with some example about siblings of people with eating disorder. And so when you have a patient, you treat family. When there are other siblings, what arrives? And we want to discuss clinically, December 14. Stay in touch with us. Thanks a lot, and Thanksgivings to everybody. Ciao.
Thank
See you
you.
again.
Bye.
See you again. Ciao.
See you.